Hello everyone, it's a great honor for me to welcome all of you to the 5th webinar of IAPWC Karnataka. I am actually indebted to IAPWC team. My team has been doing very well. Dr. Sumita, Dr. Ramya, Dr. Kalai Selvi, Dr. Shanti, Dr. Richa, Dr. Bhavna has put up a lot of effort to bring this webinar to you guys. So kudos to their effort. Yes. The topic of today's webinar is role of physiotherapy in COVID-19 hospital to community rehab, which is very, very relevant topic for all of us since we have never ever seen such kind of condition in our life. So it's not that we are aware of everything from before. So it will be really interesting to hear from sir. Today's guest of honor is Professor Dr. Ranjan Samuel. He is a Dean Faculty of Physiotherapy in VMRF, Salem. He has been professor for more than 20 years. He's also a Central CC member. He has been recipient of various awards, including Lifetime Education Achievement Award. He holds certification from US in manual therapy, and he's also certified matrix rhythm therapist. He has been speaker, resource person, judge in various professional gatherings. We welcome you, sir. We are really honored to have your presence here. I would request you to just say a few words about this webinar.
Thank you, Dr. Puja. First of all, I would like to appreciate the IAPWC team, all the whole, and the South Zone IAPWC and also the National Wing for taking all these efforts in these critical situations and making all the people actively learn and make their lockdown period very useful. And conducting series of webinars is not an easy job at all. And I think like with the poor technical knowledge, they are doing a wonder. And all the topics like are varied from different areas. We have topics on sports, we have topic on botulinum, and then we have now about the need of the hour, the COVID-19 practice. So thanks to all, and most of my faculty and my students are attending this webinars and getting benefited. So on behalf of them also, I thank IAPWC for their efforts.
Thank you.
And COVID-19, I think government now says we have to learn to live with the virus. And actually, like, it has changed our living at all. It has changed a lot of things, and I feel a lot of relations have changed. The international relationships with countries have changed. Relationship inside the family has changed, and so many things have changed. Patient and physiotherapist relationship has changed, and also teacher and student relationship also have changed. Like, we are all sitting in front of screens and talking to them. So with a lot of changes, I think we need to really cope up and then get back to know like really what we have to do post-COVID, like now, like how we are going to go about and get things done. And I think like now we have a wonderful speaker from Singapore, and I would like to welcome Dr. Balachandran for accepting the invitation and sharing his experience with all of us. And I think like it's a right move for all the physios to take up this, and then let us all treat in a new dimension and take care of our patients. Thank you for the opportunity.
Thank you so much, sir. Those were the word of encouragement. So let's start our webinar. Our today's speaker is Dr. Balachandran, who has joined us all the way from Singapore. He has 19 years of clinical experience in the area of cardiopulmonary and ICU rehab. He currently holds the position of principal physiotherapist in the cardiopulmonary unit at Woodland Health Campus, Singapore. He has won several awards in recognition of his contribution in teaching and research work. He has published many papers nationally as well as internationally. We welcome you, sir, and we are really looking forward for your talk. Now, all yours, sir.
Can you see my screen, Pooja?
Yes, I cannot.
You have started, sir.
I can see you, but I can't see the slides, sir.
Oh, okay. Okay, maybe let me just try to get it. Yeah, now you should be able to see, I think.
Yes, yes, sir. We are.
Okay. Maybe Pooja, can I go ahead?
Yes, please, please, sir.
Okay. Thank you very much for inviting me. Thank you, Professor Rajan, for giving that insightful talk. The relationship has changed. I have realized after listening to you now. I didn't realize that, but after you mentioned that, now I'm reflecting back. Yeah, a lot of relationship has changed. Uh, I will just go into my topic first, and then we can have some Q&A at the end. Basically, I'm working with COVID-19 patients for past 3 months. Singapore is one of the first country hit after China for COVID-19, basically because of our connection with China. We are very close to China. So we are one of the first countries to be hit with COVID-19, and we are still fighting this war. This war is not ending. So I'll give you my insight and also share some international perspective about COVID-19 in relation to physiotherapy. This is going to be my contents for today. We will see what is the current status of COVID-19, and we will try to understand the pathophysiology and try to make relevance to physiotherapy interventions. And then we'll talk about prone positioning, which is being talked very much after COVID-19. And also we will talk about rehabilitation. Rehabilitation is now starting to be talked about because initially it was survival. Now it is talked about life beyond ICU because people are surviving now and there is some rehabilitative needs. So I'll just share my experience on rehabilitation also. So this is my first slide. This is the current status. I just took this from John Hopkins just 10 minutes ago. And this is the current status. I actually did a webinar last week. Last week was 34 lakh, but now is 44 lakh. Within 1 week, the number has increased by 10 lakh infections. So this is the current status of COVID-19 infection worldwide. And US is hitting the top. You all know about it. And now what is surprising is Russia is coming into the picture. The death is also increasing. Initially, it was not so much, but the death in US as well as United Kingdom is on a rise. So still, it's not stopping. It started in December in China, and we are in May now. 6 months, we are fighting this battle. So what do we know about COVID? It is a novel disease. We all know it is very new. But based on the reports which we get from China, Italy, and US, 80% of the cases are mild to moderate. So they don't really cause any mortality. Is the other 20% which causes the mortality. The other 20%, 13% are severe disease and 6% are critical. When they say severe disease, this is how they classify severe disease as dyspnea, SpO2 is less, they need some oxygen support, and their PF ratio is less than 300, with some lung infiltrates, or more than 50% of the lung is being infected. So this is severe disease. Critical is they are having respiratory failure. On top of that, they have other organ failure. So that is critical. This both 20% of cases may need intubation and then may need ICU. So this is the part where the tipping is happening. Some countries cannot cope because this 20% is a huge number for them. Pooja, the speed is okay, Pooja? I go on?
Yes, yes, sir. Yes, sir.
Okay. So I have mentioned already, so approximately 20% of the patient needs hospital care. Most of them, rest 80% may not need hospital care. The 20% which I mentioned may need hospital care because they are going into these kind of failures: respiratory failure, kidney failure, cardiac failure, and liver failure. So these are the organs which are affected with COVID-19. It is not a disease of lung alone. So that is what we are trying to realize of late. So most of the patients who are affected severely may need mechanical ventilation and also may need vasopressor treatment because they are going into sepsis. This sepsis is causing multi-organ failure. So this is something we are trying to know about it. And very important thing, what WHO has recommended is, right, even though these patients are severely infected and are very critically ill, right, they are still encouraging active mobilization in ICU. So this is a recommendation from WHO. We will just share that with you all. Okay, so with this background, right, I'm just trying to go into the pathophysiology of coronavirus. So what they have found is this coronavirus has this attraction towards ACE inhibitor, ACE2 receptors. So these ACE2 receptors are present in your alveoli and present in your other organs also, but they are more having affinity towards your lung. So that is where it starts. It goes into your lung alveoli, binds to the ACE2 receptor, and it gets encapsulated, and then it starts multiplying. When it gets encapsulated and starts multiplying, that's where you get this clinical pneumonia. So when there's clinical pneumonia, the body's reaction is it tries to fight that virus, tries to go and cause damage to it. But in this coronavirus situation, what we have is cytokine storm, means there is excessive immune reaction. So the whole area of the lung gets inflamed, and that causes massive alveolar damage because cytokine comes as and self-destructs itself and tries to destruct the virus. But in that process, it causes a massive damage to the alveoli. That in turn causes capillary leak. A lot of interstitial fluids starts leaking into the alveoli, and that's where you get your ARDS. So this is the pathophysiology of a coronavirus. This is how the patient becomes very breathless, very hypoxic. What is something very interesting they also try to publish is there are two types of coronavirus. One goes into this ARDS form, and one goes into the other form where it affects the capillaries in the lung and causes the Q to be affected more than the V. So when we talk about VQ, ARDS is affecting the ventilation, and the other type we are trying to see is there is pulmonary embolism, and it causes hypoxemia very badly. So there are two types of coronavirus we are trying to see now. And whatever it is, at the end, they present as both ARDS as well as kind of pulmonary embolism. And there is heavy damage to the lung, and then it leads to interstitial lung disease. So that is the outcome of a severe infection with coronavirus. So at this point, right, I just want to start off. It is very, you all know we cannot treat coronavirus because it is a virus, we cannot treat it. Prevention is the way to go about. And since it has become a pandemic, most of the countries are trying to go into this pattern of trying to flatten the curve. What do we mean by flattening the curve is, I'm just pointing my mouse to this point. The red bar right here, what it says is that you don't do any intervention and then you allow the virus to spread, it goes out of proportion. And this dotted line is your threshold. Threshold means, right, every country has some threshold number. It can manage this number of patients if they are getting infected. But if you don't manage, it will go beyond the threshold, and it is devastating. It is like the Spanish flu. The disaster of death is going to be very high. So if you can flatten the curve, if you don't allow this to go beyond this dotted lines, then you can manage this outbreak. How can you flatten the curve? There are only three ways you can do this. One is by contact tracing. You all know by now what is contact tracing. Like once you know a person is infected, you try to trace who were near to that person and then quarantine them. So that is the first primary intervention we need to do. If you don't do that, then you will go into this red zone. On top of that, right, we also don't know who is infected because this is a very, very intelligent virus, they say, because it is asymptomatic. It doesn't show any symptoms, but it can infect a lot of people. So that is why they're also emphasizing on social distancing. So now these are the three kind of things which we all need to follow. The contact tracing and quarantine is followed by the government of that country. Social distancing is by us. We need to have that social distancing. If you don't have social distancing, we are spreading the virus. I just want to mention that here. We will just go on. So now I will just bring back what is the practice in Singapore. As I said, we are very early into this war. We are into this war from January. So that is how Singapore it is, and we are still fighting this war. So our operational principle is anytime you have a novel virus, the operational principle is try to minimize exposure to this virus. And physiotherapists have to be one of those people who should not be exposing themselves until unless it is indicated. So that is the operational principle. So we keep that principle in Singapore. The clinical principle is, in case if it is indicated and you have to step in, right, the first thing we need to do is wear proper PPE. Report from China, what we know is the healthcare people who died is because in the initial stage they didn't know about the virus and they were not wearing their full PPE. So that was the reason why there were a lot of healthcare deaths in China. So the first thing we need to do is, if you're trying to see a coronavirus patient, full PPE is a must. I'll just go through this full PPE. N95 is your respirator. It's not a surgical mask, it's N95. You need to wear N95 for coronavirus. Visor is to protect your eyes. Full gown is to protect your body. Don't expose any part of your body. And plus minus is PAPR. It is an air purifier which you try to protect your head as well as your other places of your face. So that is PAPR. This is plus minus. Some centers practice, some centers don't practice. So that is the first thing you need to do. The second thing is, if you're trying to see a patient who's intubated, you try not to do open suctioning. So sometimes we disconnect the ventilator to do ETT suctioning. So we are not encouraging that to be practiced here, because when you do that, you are creating aerosol generation. That is not good for healthcare workers. So we don't do that. We don't do manual hyperinflation for any intubated patient, because if you want to do manual hyperinflation, you need to disconnect from the ventilator. Again, you're generating aerosol generation procedures. So we don't need to do MHI. What can we do when you go and see this patient? What can you do? So we are going back to basics. All we can do is positioning. We need to assess the lung from outside with X-ray or CT thorax, and then you go. Sometimes you cannot even auscultate if you are doing a PAPR. So you may have to depend on your palpation skills. You just have to palpate, and then you just have to position the lung. So that is what you can do. And in Singapore, we have this facility of closed suctioning. We can suction ETT without disconnecting the ventilator. So we are encouraged to do closed suctioning and only positioning. So now I'll just mention briefly about prone positioning. If you think the positioning is not working, so what is recommended is prone positioning. We have learned prone positioning from ARDS patients last time. So we are just practicing the same for this coronavirus patient too. So this is what is our clinical principle when we are trying to manage coronavirus. I'll just summarize this slide because it is a heavy slide. Operationally, we should not expose ourselves. We should work as a team. Don't try to go and see all your coronavirus patients. So that is the first operational principle. You only see when it is indicated. I will try to share what is that indication in my next slide. In case you are seeing, make sure you wear your full PPE. Avoid any aerosol generating procedures such as open suctioning, disconnecting the ventilator. Go for your positioning as your treatment and close suctioning. And if all those don't work, just go for prone positioning, which you have to work with your doctors and nurses. Pooja, is everything okay, Pooja? Can I go on?
Yes, sir. Go ahead. It's very interesting, sir.
So I just want to add on. Initially, our PPE was what I mentioned, but later there were some recommendations, right? If you don't cover your hair, you are also trying to spread this virus. So if you're going to go and see the patient, you need to cover your hair. And very important is shoes. You cannot go in without covering your shoes. Initially, we took it for granted. We just wear the shoes and go in. But shoes are carrying, because this is a droplet. So when it is dropping, it will drop on your shoes and you're carrying that virus out of that place and spreading it everywhere. Italy was affected. One report came, Italy is affected because of the shoes. So now what we have done is we need to wear two shoes. The shoes which you are wearing in that ward, you cannot bring it back from the ward. You just have to leave it in the ward. Even for that shoe, you need to cover the shoe when you're going into the room, and then you dispose that cover inside the room and then come out. So that is something added on to our PPE practice from what I shared earlier. I'll just go on. This slide is a bit small, so I'm just going to expand and then I will come back. So just now I said we should not see COVID-19 patients until unless it is indicated. Then what is the indication to see these patients? So basically when they are in ICU, there are two indications. Either it is for respiratory reason or it is for mobilization reason. Respiratory reason, we only see if the patient is having lung collapse or severe type 1 respiratory failure because of mucus plugging or because of heavy consolidation. So these are the two reasons we see these patients. If it is for routine secretion management, the patient is having secretion, we allow the staff nurse to perform routine suctioning. We don't go in. So the indication to see a coronavirus patient in ICU is if there is a lung collapse. So that is the indication. So if I go down this flow chart, if the PT reviews and the chest improves, right, then PT will just monitor and see when it is needed. Not after that, he doesn't see the patients regularly also. The next visit also is again based on the need. Not routinely after a lung collapse, we don't see the patients routinely every day after that. So it's again based on the need. If the patient doesn't improve, then maybe we need to talk to the medical team and see what else can be done, because your kind of what you have in your hand is only positioning. Sometimes it doesn't help, then you may have to talk to the medical team. So don't try on your own. So that is what I tried to mention here. So this is the first indication for seeing a coronavirus patient. The other indication is mobilization. So in Singapore here, we actively mobilize all intubated patients from day 1 or day 2. They are not left to lie down in bed. So we have a criteria. I'll just share that criteria. The criteria is basically the patient should be conscious, able to obey commands. The cardiovascular system is stable, not on any inotropic support. There is no arrhythmia or ischemia. Respiratory system is having some decent support. It's not on very high support. If FiO2 is less than 50% and PEEP is less than 8, then we say this patient can be mobilized. The muscle power should be intact. If the muscle power is not against gravity, then we cannot mobilize this patient. Bloods and biochemistry should be normal range. So this is the criteria. If the patient meets this criteria, we will mobilize the patient to sit out in chair. And again, in Singapore, what we have done is the nurses will do this. The physio doesn't have to do this. The physio will walk the patient who is intubated with ventilator. The nurses will sit the patient out in chair. So we are just trying to practice the same thing. And we'll only go if the nurse cannot manage this patient because of lines, because the patient is too heavy, or for some reason, if the nurses cannot manage, only then the physio will go in to mobilize this patient. So this is the second indication to see a coronavirus patient in an ICU who is intubated. I will just go on so that we can take more questions later. So I mentioned the nurses will mobilize my patients. For this COVID-19 situation, we have trained our nurses specially how to position the patient if the lung is bad, how to position the bad lung up and the good lung down. Because the nurses, we keep teaching them, but I think somehow they don't get it. So we did this revision once before COVID-19 started in our ICU. So we taught them about positioning. And then the other thing we taught them is, normally when we mobilize the patient, we disconnect the ventilator for a short time just to transfer the patient. But for this situation, COVID-19, we taught them how to mobilize a patient without disconnecting the ventilator. And this is some training we did for our nurses. So this was our approach in Singapore for COVID-19 patients. So now I will just go on to share some international practice. So how have they managed COVID-19 patients from a physio perspective? This is an article which is published this year in March. This is actually a kind of expert opinion. A lot of experts in cardiopulmonary have come together and then they came up with this recommendation. This recommendation is based on the previous experience with the ARDS. So that's how they came up with this recommendation. So the first question they asked is, who should physio treat? Which is like similar to what we have discussed earlier. We should not go in until unless there is indication. So they came up with two broad statements. If the patient doesn't have any secretions, if it is dry cough, then physio should not go in. But if the patient has an exudative consolidation and there's secretion, then the physio should go in. So that is how you decide when to go in. COVID-19 is very unique. Some patients are dry, some patients are productive. So you cannot just go in for all COVID-19 patients. You need to assess your patient before you go in. So this is the first recommendation. And then they expanded this recommendation by giving some more information on it. So I'm just going to share that. If you see on your left-hand side here, if it is mild symptom, no X-ray changes, dry cough, physio is not indicated, you don't go in. And there is pneumonia, but the oxygen support is very less, and it is again non-protective. There is no secretion. If it is protective, the patient is able to cough on his own. Again, physio is not indicated. But if the patient is having pneumonia and then he is also having other comorbidities like neuromuscular disease, spinal cord injury, bronchiectasis, which makes him difficult to clear his secretions, then they say maybe physio can just go in to treat this patient. So this is the recommendation. The other recommendation they made here is if you are doing physio for this patient, you need to ask the patient to use surgical mask. The patient should wear a surgical mask. The patient cannot cough in open air. So this is a very important recommendation they have made. Again, the idea is try to stop the aerosol generation from the patient. So that's the idea here. I'll go on. The other two is a patient becomes more severe, then again the patient has to be seen by physio. So these are the other two recommendations they came up with. Lastly, the recommendation is for mobilization. They said if the patient can be mobilized, the patient should be mobilized in ICU. So again, like what I showed in the flow chart, there are two indications. One is for respiratory system and one is for mobilization. Again, you go in only if there is indication for either of respiratory system or for your mobilization. Pooja, I can go on, right, Pooja?
Yes, sir. Can you just adjust your video a little bit so that we can see your face more clearly? Yes.
Okay, Ken. Yeah. Ken, Pooja. Now, okay, right, Pooja?
Yes, yes.
Okay. Now, right, I'm using this word called aerosol generating procedure. It is not commonly used in our day-to-day practice. What I understand aerosol generating procedure is when you cough, you create some aerosol, that is aerosol generating procedure. And then when you give nebulization, then you generate aerosol, that is aerosol generating procedure. In our hospital, if you have any influenza infection and you're trying to give nebulization, what they do is they will switch off the fan, they will curtain the patient so that it doesn't go and affect the other patients. So that is how we control aerosol generating procedure. Because it is just a droplet, if you just close the curtain, it's good enough already. Now with COVID-19, this aerosol generating procedure kind of word has got so much of attention that we have to think what is all aerosol generating procedure. Now if I ask back, right, is my respiratory interventions apart from coughing, is there any other respiratory intervention which is aerosol generating procedure, right? The answer is all my respiratory interventions are aerosol generating procedure. In fact, all my physiotherapy interventions are aerosol generating procedures. I'll just go through this point here. I just expand this a little bit just to make you see. Here they've defined what is aerosol generating procedures. Many respiratory physiotherapy interventions are potentially aerosol generating procedures. While there are insufficient investigations confirming the aerosol generating procedures of various physiotherapy interventions, the combination of cough for airway clearance makes all techniques potentially aerosol generating procedures. So what they're trying to say is, right, if you do anything and the patient coughs, the patient is generating aerosols. So what can make the patient cough? One is directly asking the patient to cough is going to create aerosol. If you position and do drainage, the patient also may cough because the phlegm is moving, the patient may cough. So it is positioning is becoming an aerosol generating procedure. And on top of that, if you do vibration, if you do percussion and manually assisted cough, all becomes aerosol generating procedure. Any positive pressure like cough assist, if you use, it becomes aerosol generating procedure. If you use PEP, positive airway expiratory pressure devices like bubble PEP or oscillating PEP, it becomes aerosol generating procedure. Suctioning is aerosol generating procedure. I have mentioned about manual hyperinflation because it creates that flow, expiratory flow. It is also aerosol generating procedure. Suctioning we mentioned already. Saline instillation. And the last one, a very tricky one. If you mobilize a patient, it is also aerosol generating because when you mobilize the patient will cough. So what is the implication of understanding this is when you are trying to see a COVID-19 patient and you are going in to mobilize the patient, even then you need to wear full PPE. That is the implication of this slide, which we were overlooking because we were wearing PPE only when we are doing chest physio. We were not wearing PPE when we are doing mobilization. But it seems that we need to wear. If you're lucky, if the patient doesn't cough, you're lucky, you're safe. If the patient coughs, you are very unlucky. Nobody can help you now. So that is what I'm trying to share here. Now, the other thing they share, right, cough etiquette. I think this is already there. All physiotherapists will follow this, but it's just that it is being reinforced here very much. Always ask the patient to turn away from you. When the patient is coughing, don't ask the patient to cough on your face. So you have to ask the patient to turn away. And then you should ask the patient to catch their cough. This is like having a tissue paper or something readily available. When they cough, they just catch their cough so that there is no aerosol generating in the air. So these are the two things. And then they also say physiotherapist should step 2 meters away when the patient is ready to cough. I hope we all can practice this. Sometimes it is difficult, but they have recommended this. So I'm just sharing their recommendations from the international experts. Okay, so I hope you are all following me. I'm just going to go to the next slide. The next slide, I just want to highlight bubble pep. Bubble pep is something very commonly used in Singapore. It is nothing but we try to fill some water in a small kind of bottle, and then we use a pipe, a large bore pipe, and ask the patient to blow in water into it. When you blow that, the patient can vibrate these airways, and then it will loosen the phlegm, and the patient can clear secretions. They say bubble pep is worse than coughing, because at least coughing you can control, catch the cough by using a tissue paper. When you use bubble pep, you are generating a lot of aerosols. So don't use bubble pep when you're treating COVID-19 patients. So that's the recommendation. I just wanted to share that also. Okay, we have come up with a video how to teach the patient on their own. We will teach first, and then we will give this video. We come up with a QR code. The patient can scan. Everybody uses handphone in the ICU here. They have data plans, no problem at all. So we give the QR code. They can watch that, and then they can practice and then clear their secretions. So the best recommendation is patient clear his own secretions. Nobody should be inside the room. So that is why we came up with this video. I have shared this link with Shanti. I think she will share with everybody. So you can watch this, and then you can share it with your patients. This is in English. Please feel free to translate if you want to translate into your local language. So this is my first video we have done for our COVID-19 patients. Pooja, any comments, Pooja? Can I go on?
Yes, sir. You can go on. But
Okay.
will you be playing this video, sir?
No, I may not have time.
Okay.
Ken, we will see how. I don't think I have time. So now, right, I mentioned one is aerosol generating procedures. Now the main treatment a patient should get during the acute stage is prone positioning. Proning is only done in ICU for a patient who's sedated and who's intubated. Proning is not done for a patient who's awake. Now COVID-19 is pushing us to the edge and saying that you cannot just wait for the patient to get intubated. So the studies coming from Italy, this proning was discovered in Italy. So the studies coming from Italy, what they have done is they have started to prone people who are not intubated, who are awake. They have done this a few years ago, and that study becomes so valuable now. Now everybody who is COVID-19, who is on oxygen support, should be prone when they are lying down in bed. So that is the standard of treatment for COVID-19 patients. So now we are extending proning from just ICU patients also to awake patients who are in general ward, who are on the fence, because they may get worse or they may get better. If you are proning this patient, the chances of them getting better is very high. So that is why we are proning all our conscious patients now. Have you ever seen a patient lying in prone who is conscious in a hospital bed? The nurse will get mad. The nurse will not allow. Now we're asking the patients to lie prone. So that is like what Professor Rajan has said, change in relationship. This is change in care, what we are doing for our COVID-19 patients. There's a rationale why we are lying in prone. If you all know, most of our lungs are in the posterior area. So when you're lying supine, it becomes a dependent area, and this ARDS is all affecting the dependent lungs. So when you prone the patient, there are three things happening. One, you empty that area from the fluid which is filled up. So once you empty that area, you can aerate that area. And then you are matching the VQ. Normally, ventilation is good in the anterior aspect. Perfusion is good in the posterior aspect. When you prone them, the posterior aspect becomes anterior. So ventilation is good. Perfusion remains the same. It is still in the posterior area. So VQ matching is happening. So hypoxemia is coming down. And the third one is the heart weight is taken off from the lung. So the lung is free and it can expand much better without the weight of the heart. So that is why prone is very, very good for ARDS patients. So VQ matching is happening. You reduce hypoxemia and then you reduce shunt. So this is the rationale for proning, and we are doing for all our patients in general ward as well as in ICU. And it is really helping these patients. I'll just share one study which I mentioned just now from Italy. So this is the study which is from Italy. It is done in 2017. So what they've done is they have started to prone patients who are awake and they're needing NIV. So what they found is, I'm just going to show this slide. This is your PF ratio. If you see PF ratio here, when it is the same settings, right? When the patient is in supine, it is around 120. When the patient is prone, it is going to 150. And you can see consistently, it is going up in all the prone positioning. There is no change. The only change is the patient is in prone. So the PF ratio is increasing when you're proning the patient, even when they are awake. So that is why proning is encouraged in all ARDS patients as well as now COVID-19 patients. And this is the other video we came up with. I've also forwarded the video to Shanti, how to prone awake patient. So this is a stepwise approach. And then there's a QR code at the bottom. The patient will scan the QR code and the patient will prone on his own. The problem with COVID-19 patient is they're all in isolation wards. You cannot go in as and when you wish. If you want to go in, you need to wear full PPE. So it is a very tedious process to go in and see these patients. So that is why we are creating all this video with the QR code so that the patient can do themselves. So this is one more video we have created for all our COVID-19 patients. I have this workflow for proning. So basically, I just want to focus here. These are the criteria we need to look for. If the patient is having cognitive impairment, you cannot prone a patient because the patient will not tell you if he is comfortable or not comfortable. So you don't prone a patient who is cognitively impaired. Facial injuries, please don't prone. If the patient is acutely short of breath, then please don't prone. If the patient recently had a heart attack, you don't prone. Obviously, if the patient is pregnant, you don't prone the patient. And if there's any abdominal distension for some reason, you don't prone the patient. Neurological is if the patient is having a history of seizures, we also try not to prone this patient. And there is significant weakness and the patient cannot turn on their own. This is again the catch here is because the patient is in isolation room, and if there's not help available, the patient may be suffering in prone. So we don't allow the patient to be in prone if they cannot turn themselves. So that is one of the indication. Spinal injury, again, we don't prone. Any recent injuries, which is cardiac, abdominal, or spine, we try not to prone. And vomiting, if the patient has a history of vomiting, please don't prone. So if the patient clears all these things, you can prone the patient. So I just want to focus on this criteria. So this is the criteria we are following for our hospital patients. We just go down. Okay, so now now the status now is, since we are in this for a very long time, patients are surviving and they are coming out of ICU. When they're coming out of ICU, right, there was a very nice statement in one of the articles, a fate worse than death. So this is the statement of the article for a patient who's coming out of ICU. Means that a fate worse than death, right? I'm rather die in ICU rather than leave alive after coming out of from ICU, because I am so disabled, I cannot do anything. I'm so dependent for everything. So that is the status of a patient who comes out of ICU after severe infection. And that is the status COVID-19 patient can go into if we are not treating them in the right manner at the right time. So we are conscious about it, and then that's why we are starting mobilization as early as possible in ICU. Why it is so? Because with COVID-19, it is more dangerous because it doesn't only affect the respiratory system, it also affects your cardiac system, also affects your musculoskeletal system because of the drugs you're giving. On top of the cardiac system, it also affects your renal system, which I have already mentioned earlier. This cardiac system is a very tricky thing. All our patients who are in ICU, their cardiac enzymes are high. They are having heart attack, but we are not aware of it at all. And this is going to affect your rehab in the later stage because their heart is also weak, their respiratory system is also weak, and they are having a very weak muscle. What is a better combination? This is looking like a very perfect storm for a patient to get disabled. Respiratory system is gone, cardiac system is gone, musculoskeletal system is gone. So we have to be very, very careful when we are trying to rehab this patient. It has to be very gradual. So that is the awareness I want to create here. Rehab is not going to be straightforward for a COVID-19 patients. Okay, so this is a very generic slide. I think everybody knows about this, but I'm just trying to bring it back to COVID-19 patient. This is an ICF model we use, trying to identify impairments in a patient. So if you try to apply this to a COVID-19 patient, they're going to have impairment in their lung function. As I said, because of ARDS, they're going to have interstitial lung disease because the lung is going to be fibrosed and they're going to have interstitial lung disease. It's going to affect their lung function. Their respiratory muscles are going to be weak because they are being intubated for a very long time and they are not using their respiratory muscles. So that is going to be weak. And their limb muscles are going to be weak because they are not moving. And on top of that, they are being paralyzed for proning for a very long time. Proning in an ICU patient lasts for 16 hours and they have to be completely paralyzed for more than 5 or 6 days. You imagine what will happen to the musculoskeletal system when they come out of this kind of paralysis. So these are going to be the impairments. They are going to come out if they are coming out of the ICU. So with this, right, if you go into activity, their exercise capacity is going to be very, 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 very low. They can, so when just to share some experience, when I first see the patient, they can hardly walk 2 meters. That is the status. Why go so far? They hardly can stand first. They are going to be bed bound and they cannot even move out of bed. They cannot even turn in their bed. So that is going to be the status. When they walk, their exercise capacity is almost near to zero. So that is the exercise capacity. Even when they are improving, right, this is going to take a long time. Their exercise capacity as well as their gait speed, they're not going to walk like what they were walking before. So all these are going to be affected because their respiratory system, their muscular system is affected. On top of that, your cardiac system is also affected. So you just have to keep this in mind. These are some outcome measures which you can use to track what is the change the patient is showing with rehab. So just want to share this. This is a very generic slide. We are using this for all our ICU patients, and it is very applicable for COVID-19 patients also. Some recommendation has come from American Health Organization as well as World Health Organization. So I'm just going to share this recommendation. So rehabilitation consideration during the COVID-19 outbreak. So this is the key message. We are expecting COVID-19 patients to have impaired lung function, which I have shared already, physical deconditioning, muscle weakness, which is very obvious. What is making this problem more complex is the delirium. Patient will not talk to you. You talk to the patient will talk something. How to treat a patient who cannot get connected to you? This is going to be, I don't know, it's going to be a nightmare if you're trying to see this patient with all this combination. Patient is weak, patient cannot listen to you, patient doesn't want to obey you. How to help this patient? But we are facing this situation here. On top of that, they cannot eat. So their nutrition is affected. Cognition is affected. Physically, they are affected. I cannot explain. I think I'm telling you the problems I'm facing here. So all these are going to be a problem when a patient comes out of ICU surviving COVID-19. Survival is one. Living after surviving COVID-19 is a big challenge. It's really a Hercules challenge to live after COVID-19. But we are trying our best to help these patients. But we need to be aware that it is not an easy challenge. I just want to share that. So this is the recommendation from that the World Health Organization as well as the American Health Organization. So I'm just trying to summarize what they've written here because it is very small. In the acute stage when they are in ICU, right? So what is recommended is proning. Make sure they survive that infection. Only proning can save lives for COVID-19 patient. Ventilator cannot save lives. So this is the statement coming out. If you ventilate a patient, right, the patient will die. If you prone the patient will survive. So that is the truth I want to share here. Once the patient is extubated, you try your best not to re-intubate the patient. How will you not re-intubate the patient? Try to make sure the patient clears their own secretions. So that is your ACPT technique, which I've already shared. And we come up with a poster and then we keep it inside. And as early as possible, try to mobilize these patients in the ICU itself. If you do that, you have an easy journey later. If you don't do that, you have a very difficult journey when they come out of the ICU. So that is the first phase, acute phase. In the subacute phase, as I've already shared, they have multiple level problems. You need to assess everything, and then you have to appropriately train them. Resistance training, nutritional support, because you cannot just train a muscle without nutritional support, because it's protein. You need protein to build up your muscle. So you need to make sure nutrition is supported with your resistance training. As a physios, we don't think about nutrition, but now we need to think holistically. We cannot just think what we can do. And again, since these patients are not moving very well, there will be tightness. So stretching is part of your intervention. And then once with this, right, you need to find out how to get their endurance going, because the exercise capacity is going to be affected. You need to find ways to build up their endurance. And once everything is going on well, you try to train their gait as well as balance. The worst thing to happen is you train everything and then the patient falls and comes back with some hip fracture, finish already. All your effort is gone. So you got to be very careful, and you need to assess everything and then train accordingly. We have come up with one more exercise, which is called as Teh Terik Workout. Everybody will be wondering, what is this Teh Terik? Teh Terik here means, right, you are trying to make a tea in air. So that is called Teh Terik. It's a very local term. So we are trying to come up with a concept how to form exercise with a Teh Terik. So it is more engaging. Otherwise, the patients are not engaging. As I told, the patients are having cognitive impairment. We need to come up with some innovative ways to engage. I've shared this video also to Shanti. I think Shanti will share with you now. We are doing this for all our patients in general ward. So some strategies which we already practice for ARDS patients who are coming out of ICU, I'm just sharing here. This is the strategy to get an optimal outcome. Make sure you always monitor their cardiac and respiratory response, because they will desaturate. And COVID-19, right, there's something called happy hypoxia. They will not complain of breathlessness, but they will be desaturating to 70% or 75%. So you need to monitor the SpO2 carefully when you are exercising. Heart rate has to be monitored. And then always exercise at this intensity. This is just a guidance. Don't just follow this. If the patient is very weak, you can just go lower than 50%. But if the patient is okay, you can start at 50% just to get some benefits of that endurance training. And the next one is resistance training, which has to be 70% of their 1 RM. So otherwise, there's no benefits. And always have a team-based approach. Don't think only physio has to do physio work. It is a teamwork. Here in Singapore, we work with the nurses. The nurses do some part of the work, and the physios do some part of the work. So it's a team approach. So this is something I just want to share. We do this for all our ICU patients, and I think we are also applying for COVID-19 patients. I think this is too small. I will not show that. I will just skip that. Just to summarize what I have presented today is, first point is you have to step in only when it is absolutely indicated in the initial stage, because we need to protect both the patient as well as the healthcare workers. Don't expose yourself unnecessarily. That's the first thing. PPE is very, very important. Whenever you see a patient, make sure you wear your PPE. In the acute stage, when you're treating, prone positioning to make sure they survive. And then once they are extubated, make sure ACPT is done so that they don't get reintubated, and mobilize the patient as much as possible in the early stage. Again, this can be done through nurses, through some exercise program which is given to the patient. Physio doesn't have to step in to do this. So that's my message here. In the subacute stage, as I shared, you try to assess all the system and then apply based on the impairment. Whatever impairment is there, you assess that and then you apply according to that. So that is all I have for today. Pooja, I will just give this screen back to you. You can take over.
Yes. Am I visible now?
You are visible, very visible. Pooja.
Yes. Thank you so much, sir, for that information. It was actually an eye-opener, not only for me, for all the people who have attended here. And when I say, I'm not saying just for a formality, it's actually an eye-opener. Like, I was not knowing that it can be with sputum. I was absolutely not aware, because in India, it is only about dry cough, dry cough, dry cough.
Yeah.
It's almost an eye-opener for me. Lots and lots of you. So I will start to shoot questions. So one question which is very personal is, I don't work in a hospital setup. I have a clinic setup. And when we talk about social distancing, we absolutely can't do it with our patients. So there's no distancing happening there. And in clinic setup, generally we don't get any infective patients, but yes, they can be the carriers who may be. So in that case, should wear a PPE kit?
Uh, Very nice question, actually. Um, my advice here, based on Singapore, right now, once it is in community, so you have different zones. We are in an orange zone now. I don't
Yes.
know where is India currently now. If it is the infection is spread in community, we go into orange zone. Means that anybody in the community can have.
Yeah.
So once you are in that stage, a compulsion here is everybody should wear a mask. When you're going out, everybody should wear a mask. And now, if you just take that into your clinic, right? I don't meet patients when I go out, but I still wear a mask. In a clinic, I'm trying to go very close to them, talk to them, sit with them, spend some time with them. Then I need to wear my full PPE because that is a must based on epidemiology studies. When it is in community, take all the precautions. Anything you spend more than 15 to half an hour, you are considered you are in close contact with that person. So if in your clinic, right, you're spending more than 15 to half an hour time, right,
Yes.
it is not transient. So it is highly recommended you wear all your PPE. You need to wear your yellow gown. You need to wear your visor. You will look very different, but I think this is the standard we are practicing here.
Okay. Okay. Thank you so much, sir. And can you compare between India and Singapore? Are whatever you said about Singapore can be completely applied to India as well?
Wow, Pooja, this is the question I'm constantly getting. In my previous webinar also, I got this question. It is very difficult for me because every time I try to have the webinar, I'm trying to ask people to share what is the practice there. I'm not getting that practice at all. I try to watch news and other stuffs, but I don't get enough information what is happening there. But what I see in the public, I think they are wearing masks, so that is good. They don't go out without mask, and they are keeping social distancing. But in a hospital setting, how they are managing, I think it is international standard. I think they are following WHO. I feel it should be on par like what is in Singapore, because even Singapore is referring to WHO. We don't create our own. The only advantage Singapore has is SARS. We suffered this in 2002 and 3. So we have this experience, what we should not do. So even when WHO said you can allow visitors from China, we said we will not allow. We went against WHO and said we will not allow, because we know once these are all imported cases. Once they come in, they will spread in your country. So we said no. So we follow WHO, and then if I say that, then India should be following WHO standard. So it is going to be on par with Singapore.
Okay. Okay. Sir, how is the mobilization done? Is there phases of mobilization for COVID-19 patients?
Again, very good question. We apply what we know already. We don't treat COVID-19 patients specially. What we don't do is we don't unnecessarily go in. For example, if it is a normal patient, I will just go in on second day when the patient is intubated. I will just go in and make sure the patient is alert and then able to do something in bed. But now I don't do that. But when I know this patient is very stable, is coming out of this infection, and then I feel this patient can be mobilized to sit out in chair. So the best we can do for now is sit the patient out in chair. So we are trying to do that with the help of the nurses, and at the earliest. That is what we are trying to do. That's the first phase in ICU. Once the patient, because we cannot move the patient out of the bed, means out of the room. So we cannot walk this patient. So what we can do is sitting out of the bed in a chair, do some sit to stand, and then do other activities in standing. So this is the phases we can do in ICU. But once they come to normal ward, I think we do everything.
Okay. And how much phase, I mean, how many days the patients are asymptomatic? And, there are symptomatic patients and asymptomatic. Like in Mumbai, they were revealed that there were patients who were completely affected by COVID-19, but they remained asymptomatic throughout. How is that possible? I mean,
okay, very difficult question for me, but I will try my best to answer, because this is information which you should know. This relates back to your first question. You said, should I practice PPE when I see a patient in clinic?
Yes.
So the answer is yes. Even here now, our numbers are going high basically because of the asymptomatic patient. So what has happened is there's a cluster in an area. So they are not symptomatic at all. If I don't test them right, I will not know this patient is COVID-19. Only because I test them actively, they are positive. But they are just having a scratch in their throat. That's all their symptom is. They don't have fever, they don't have cough, they don't have anything, no running nose, nothing. So just a scratch in their throat, but the PCR test is positive. And they are positive for 15 days, but they are totally like, normal life.
Yes.
Only not normal is they are just contained in a small place.
Okay.
So that is the status of COVID-19. So just to share here, COVID-19 is a very intelligent virus. It is asymptomatic most of the time. Only few times it is very severe and infective now. The 20% is very severe and infective and shows all the symptoms. The 80% of the time, right, it is mild or asymptomatic. And the other good thing about COVID-19 is it doesn't affect children. So that is something very nice thing about this COVID-19 virus. It affects the old people. It doesn't affect the children.
So even if they test positive, it won't affect them much.
It is, yeah, as you said, they are more asymptomatic. A lot of people are getting from their children.
Okay.
Because they are a carrier and then they come home and then they infect their parents.
Okay.
So that kind of circuit also we found in Singapore.
Okay.
So this is a very unique COVID-19 virus. Very intelligent and very unique.
Yeah. There's a question which has come, which is like, daily, how many therapy session patients required? I think you answered that.
Yeah, I think, that's a very good question. Normally I said, don't go. First, don't go. Then now I'm saying, once it is indicated, right, we need to go because they cannot take long sessions. They fatigue very easily. So sometimes their sessions can only last for 10 minutes. So in that situation, and now, right, this is a very tricky situation. A lot of patients cannot go back to any other hospitals. If they leave acute hospital, they have to go home. So if they're not independent, in Singapore system, if you're not independent, nobody is there at home to take care of you. So you need to make them independent. So in that situation, we are seeing them twice a day.
Okay.
So initially don't see, then at the later part, we see twice a day.
Okay. Why won't we practice diaphragmatic fascia release technique in releasing dyspnea and improving lung capacity in COVID-19 patients?
Okay, that's beyond me. I don't practice, so I cannot comment on that.
Okay.
I don't know, so maybe I will not say it should not be practiced. Maybe if you think that is the reason why they are having dyspnea, if you can have some evidence to show that, any assessment to show that is because of that fascia, that tightness, which is causing them to be dyspneic and their lung capacity is reduced, please go ahead and relieve it. Because as long as the patient benefits, I think nobody is going to stop you from doing it now. We don't do it, so I don't comment. Just to go back, the pathophysiology is at the alveoli level. Alveoli gets fibrosed, so there's no alveoli. So that's the main reason why COVID-19 patients are having reduced lung capacity. It's like ILD. ILD is a progressive disease. It is not reversible. So we are also seeing the same thing in COVID-19. So I'm not sure whether whatever they mention, fascia release can help now. If it is helping, please go ahead and do it. Nobody's going to stop you.
Okay. There's a lot of questions which has come for prone positioning. So
yes. Yeah, please.
Why we prefer prone positioning, although we know that breathing difficulty will be more in prone in comparison to supine?
Oh, wow. Actually, this is I don't know whether this is a myth. By right, no. When you are a child, right, or when you are a baby, right, most of them are lying prone. And then it is because of our habit, we don't lie prone for some reason, because we have a big belly or some other reason, we don't lie prone. So we are not used to lie prone. So we are not comfortable. It is not that we become breathless. Actually, it is very comfortable to breathe when you're in prone.
Okay.
That is, again, it is a perception. It is from person to person. Physiologically speaking, you can breathe better when you're in prone.
Okay, because the next question is also the same. How far the prone is going to help in chest expansion?
Yeah, exactly. I've shown you that article already. The PF ratio is increasing. When you lie
Yes,
supine, right, the
yes,
PF ratio is so low. When you lie prone, oxygenation is better. So the
right.
main problem with COVID-19 is hypoxemia. You are dying because of hypoxemia. COVID-19 mortality is high in ICU is because of hypoxemia. So if you ventilate a patient and you don't prone, right, you cannot correct hypoxemia.
Okay.
So then they die. If you
Hmm.
prone, they survive. So this is what the findings are coming from Italy as well as other countries. So that is why proning is practiced.
Okay. Whether the COVID-19 test become positive after the person complete their quarantine period?
Again, very interesting. Initially, they said 14 days.
Hmm.
They said quarantine 14 days. Initially, they were not testing. They will only quarantine. They will just take a swab first. If they're negative, right, they have to just quarantine for 14 days. If they don't develop any symptoms, they are free from quarantine. But
Okay.
now, with understanding, what we understand is they will not get symptoms, but they can become positive because they
Okay.
are asymptomatic. So now what they've done is on 14th day, they are again testing. If they are still negative, they will be off quarantine. If they are positive, they will extend quarantine for another 14 days. So there's an incubation period varying from 2 days to 28 days for this virus. Now everybody is quarantined for 28 days.
Okay. Okay.
So
I
that is the change.
I think Ranjan sir also wants to ask few
Yeah,
questions.
sure,
Sir,
please.
Ranjan sir, over to you. You can go ahead.
Ah, yeah, Balachandra, like I just wanted to know, like you told about like two types of progression, right? Like one, like a pulmonary embolism
Yeah,
happening, and the other one is an ARDS.
yeah.
Um, so, does our role differ? Like, for example, your proning and other this thing, like depending upon what is the real progression that is happening, does our role differ?
Very nice. Our role doesn't differ, sir, but the difference is how you ventilate a patient. Sometimes they may not improve with your PEEP and your FiO2 because it is coming from your embolism. So that is where proning may somehow help this patient. Your ventilation alone doesn't help. So that is why they don't manipulate the ventilator too much if they know it is coming from your pulmonary embolism. Your ventilation management differs, but our role doesn't much differ.
Yeah, that's nice. Okay, thank you.
No problem, sir.
So I think time is less, and we actually want to hear you more and more and more. It was really enlightening, actually. So I would like to close the session here. I further extend thanks to our speaker, Dr. Balachandran sir. Again, sir, I'm telling, I was actually enthralled to listen to all that. I had no idea about it.
Thank you.
And of course, Samuel sir, for gracing the occasion just by being present. Even if it is virtual, it matters a lot to us. Uh, this will help a lot of us to take care of our patients, or to even treat patients who are not COVID-19, because the way you have told that how PPE kit is, because there is a problem with PPE kit is it cost a lot. Like every kit cost you around 350 to 550 rupees. So here in India, we are very skeptical whether to use it or not to use it. But now I'm 100% sure that we should all use it. I am indebted to Sir for gracing the occasion, for indebted to Sir for enlightening us about COVID-19. Let us close by wishing all a delightful and stimulating weekend. I am very thankful to Iftikhar sir, Ruchi ma'am, and Ramya ma'am for always supporting us, IAPWC team, and being like a pillar all the time. Let me end the topic by telling what will be the tomorrow's topic. Tomorrow topic is emotional intelligence in times of COVID-19 by Dr. A. Nag Subramaniam, who is actually from Fortis, medical director of Fortis. So looking forward to have you all for tomorrow's talk as well. Thank you so much. It's
Thank you.
time now to say namaste.
Thank you. Thank you. Bye-bye.
Thank you, sir.